And good evening again, everyone. I'm Jeff Kulikowski.
And I'm Christy Casciano. The maker of a rapid coronavirus test widely used across the U.S. and distributed by the federal government warned its test can produce false negatives under certain conditions.
Making big headlines across the country. So earlier today, I spoke with infectious disease specialist Dr. Stephen Thomas from Upstate University Hospital about this report.
The first point that I would like to make is that tests do not make diagnoses. Clinicians make diagnoses, and clinicians use tests to support their diagnosis, but they also use other tools like taking a medical history or doing a physical exam or getting other clinical laboratory results, getting an x-ray. So I think it's important for the public to understand that a test is one component that a clinician uses to make a diagnosis. I think that's the first thing. The second thing to know is that, again, this disease has only been in humans, as far as we're aware, for about 5 months now. And so all the tests that are coming online are what I would call first-generation tests. And that's important because when you are looking at the characteristics of a first-generation test, there really is no gold standard by which you benchmark that performance. And so this study that has been cited in a lot of the national media from the Cleveland Clinic, where they talk about the different tests that they used and the different levels of accuracy and sensitivity of those tests, it's going to be really important to look at the methodology that they used to come up with those results. But there are three really important elements about a test, and this is any test. So the first is, what is the pre-test likelihood that the person in front of you who you're going to test has COVID? So have they had contact with someone that has COVID? Do they have fevers or cough or shortness of breath or other symptoms that would make you concerned that they have COVID? Do they have other lab abnormalities that could be consistent with COVID, or a chest x-ray or a CAT scan of the lungs? So that's the first thing. The second thing is, what was the quality of the sample that you collected? Because if you collect a sample from the front of the nose, that's different than the back of the nose, that's different than the saliva, that's different than deep in the lungs. So that's the second thing, the quality of the sample. And then the third thing is, where in that person's infection or disease process did you make the sample? So you could have COVID and be sick today. I could test you with the best test on the market 10 days from now, and that test could be negative because the timing was not optimal. So pre-test likelihood of being infected, quality of the sample, and the timing of the collection, those are three important things you need to consider.
So, Dr. Thomas, so it's not so easy, and it's never right, especially in situations like this, to just take a headline and say, you know, there's these false negatives, and everybody gets into a panic because everybody doesn't have the expertise that you have or looks deeply into it. So to look at that headline and be super concerned is a little bit unfair and maybe too worrisome for people.
I think that's a good point. No, it is important. Again, you know, this is a very good lab, and the person who's talking about the results of these studies, this person has been doing this for a while, and they're an expert in this area. But one of the things that the NPR story mentioned is this has not gone for peer review yet. So peer review is when you feel confident about your results, but disinterested and objective parties also need to look to make sure that the methods were correct. And I'll make a point. I may sound like I know a lot about this, but that's because I have a whole laboratory of experts that I talk to twice a day who look very deeply into this and all the tests that we make decisions about whether we want to bring them in, within Upstate, or whether we want to use them to help treat our patients.
Last one before I let you go here. The governor talked a lot this morning, and he has been for a while, about really ramping up testing and get as much as they can get done in that regard, but also adding this element of a controlled tracing, so we have an idea. We're not just testing people and then they go off into the wind. We know who they are and where they are. How do you think that would potentially look if it were to happen here?
Yeah, so, what you've hit on is really one of the most fundamental elements of public health interventions. And it's not just with COVID, it's with other communicable diseases. So, tuberculosis, for example. If I were to see a patient and that patient had exposure to somebody with COVID, they had fever, cough, shortness of breath, they had a chest x-ray that looked like COVID, I wouldn't necessarily need to test them to do my job, which is to care for them, right? I would isolate them, I'd use PPE, and I would take care of them. But we do want to test so that our Department of Health then has the ability to go and trace the people that person may have been in contact with, and to find out how they're doing, and the ability to strategically isolate people or strategically quarantine people, because really that is the only way. If we can do that on a very large scale, like other places have done, China in the latter half of the outbreak there, South Korea, Singapore, these places have been able to have very blunted curves and low curves because they test a lot, they do a lot of contact tracing, they quarantine a lot of people, they isolate a lot of people, and they prevent the spread. Of infection.
Dr. Stephen Thomas, thank you so much. I know you have such a busy day, but we appreciate you coming in and spending a few minutes with us and answering some of the questions that we and our viewers, our community have. It really is very helpful. Thank you.
Absolutely. Thanks for having me.